Hi class, my name is Ben and I'm on Team Tuberculosis. I'd like to start our video out with a story of a guy named Imla. This is a true story about him contracting TB and the experience that he went through and how he was able to get through it with the help of divine intervention. As a fitness trainer and having an interest in alternative therapies, Imla was probably more focused on the mind and body than most people. But that all changed in 2005 when in just 8 months he went from cycling 20 miles a day to walking with a stick. Looking back, he says the mental challenge of his illness was equally exhausting. The first thing I noticed was feeling tired. I was going to the gym every day, but it was making me weaker. It wasn't making any sense. When I first went to the doctors, they treated me for the flu, but I just kept getting more tired. By my third visit, I couldn't ride a bike on the flat road without getting exhausted. There was too much confusion. I could see my body was shutting down, but nobody could tell me what was wrong with me. And when I tried to tell people I was sick, I didn't know what to say. I started to think it was all in my head. It was only when they opened me up and took out some of my lymph node that they discovered that it wasn't cancer. However, when I came around the next day, the doctor said, "You have TB." I was put on 22 antibiotics a day. There was relief, though, knowing what I had was curable and that I wasn't going to immediately die, but there were concerns about how to treat it. Not knowing what was wrong with me was the hardest part. You can't help but question whether it is all in your head. Looking back, it was a physical and psychological battle that I had to fight. It's the thing of not knowing, and if you don't know, then you can't accept it, and you can't fight it. Knowing what you are fighting is half the battle. I was lucky because I'm really into the spiritual side of life, so I really submerged myself in it. That was what kept me going. I think you need to find something to keep you going because it can sometimes feel too easy to quit. I liked Imla's story there, and it kind of gives you an idea of the impact that this disease can have on your life and on your body physically. Now I'm going to go ahead and jump into a brief history of tuberculosis. Tuberculosis was first discovered by Robert Koch in 1882. The bacterium is also known as Koch's bacillus. Koch ended up winning a Nobel Prize for his findings. He discovered the causative agent of tuberculosis as well as for cholera and anthrax around the same time. At the time, it was widely believed that tuberculosis was an inherited disease. However, Koch was convinced that disease was caused by a bacterium and it was infectious, and he made it his mission to uncover this mystery. This disease also dates back to ancient Egypt, where traces have been found in the spines of these mummies. Now I'm going to go ahead and talk about the etiology as well as the physical characteristics of this bacterium. The causative agent of tuberculosis is Mycobacterium tuberculosis. It belongs to the genus Mycobacterium. It is an acid-fast bacteria. So from a traditional gram stain test, Mycobacterium tuberculosis will sometimes show up as a gram-positive, but it is false. It is a bacillus bacteria. It is non-motile. It is rod-shaped, as are characteristic of the bacillus bacteria, and it does not form spores. Next, I will talk about the reservoir. As of right now, we know that humans are the only host to this bacterium. Mycobacterium tuberculosis is a disease of the lungs. It thrives in areas of the body that have lots of blood and oxygen. And the bacterium is mainly found in the upper air sacs of the lungs, and we call that pulmonary TB. This disease can also spread to other parts of the body, which we refer to as extrapulmonary TB. I just wanted to end my segment here with a few interesting tidbits regarding tuberculosis. There's a few famous people we may know that have suffered with this disease. John Keats from the Romantic era, he's a great poet. Washington Irving, also an American author of the 19th century. George Orwell, author of my favorite book, the dystopian novel 1984. Nelson Mandela, we know as a former president of South Africa, as well as a revolutionary, and Eleanor Roosevelt, the late wife of Franklin D. Roosevelt. Also, another interesting thing about tuberculosis is it is the leading cause of death for those living with the HIV virus. This is because the HIV virus weakens the immune system, and so it doesn't allow the body to fight off the TB infection.
Hi, my name is Alice, and today I'm going to be talking about how tuberculosis bacteria can be transmitted from one host to another. Tuberculosis bacteria can be spread from a person to a person through a tiny droplets released into the air from a cough, sneezing, or even talking. There are three most important factors that I want to talk about. One of them would be many people who are infected by this disease don't get sick right away. However, rather the bacteria remain dormant, reactivating even decades, years, or later. That's when lung diseases and the characteristics cough begins. Secondly, the bacteria can live in the body without making you sick. This is called a latent TB infections. In most people who breathe in in TB bacteria and become infected, the body is able to fight the body is able to fight the bacteria to stop them from growing. People with these symptoms do not feel sick. However, if TB bacteria become active in the body and multiply, the person will go from having latent TB infections to being sick with the TB diseases. Lastly, but most importantly, the TB bacteria become active in the immune systems, can't stop them from growing. When this is multiplying in the body, this is called the TB diseases. People people with these diseases are sick. They are most likely also to be able to spread the bacteria to others, most important, families members.
Hi, my name is Scott Hinckley. Before I begin my part of the presentation, I just want to mention that I work in a hospital as a respiratory therapist. So I have some personal experience with tuberculosis, and that'll be relevant a little later in the presentation. But wanted to explain my professional attire here for the video too. I'm wearing the scrubs that I wear to the hospital. I've also got the bags under my eyes and the 5-day stubble that comes after working bunch of 12-hour shifts in a row, so you're getting the full authentic experience. So I am talking today about treatment and prevention control. Well, first of all, there are two key tests that are used to detect tuberculosis. The first is the Mantoux tuberculin skin test, or TST. This is the test that a lot of people are familiar with, where they do a subcutaneous injection. With a positive result, the person's arm will have a hard, raised, palpable area at the injection site. And the reaction must be read within 48 to 72 hours. Anyone that works in healthcare has probably had a tuberculosis test like this at some point. The second type of TB test, it's a little less common, is the TB blood test, the interferon gamma release assays, or IGRAs as they're commonly called. And I'll talk about that one a little bit later when I mention a personal experience I had. So now that I've covered tuberculosis screening, I want to talk about TB treatment. The first drug used to be effective in treating TB was streptomycin, an antibiotic. And the most commonly used antibiotics used today are isoniazid, which is considered to be the most effective agent against tuberculosis because it's able to penetrate macrophages and inhibits mycolic acid synthesis present in the cell wall. INH, as it's called for short, is used in combination with 3 other drugs, including rifampin, pyrazinamide, and ethambutol. These 4 drugs are typically taken once a day for 2 months for patients with the latent and active forms of TB. I should also mention that there is a tuberculosis vaccine called BCG, which is a live attenuated strain derived from M. bovis. It's not widely used in the US, but it is used in other countries where the risk of contracting TB is very high. And finally, for the scary part, there is a form of tuberculosis. It's not very common, but it is untreatable, multi-drug resistant tuberculosis. It's defined as being resistant to at least isoniazid and rifampin. So like MRSA, methicillin-resistant Staph aureus, it's manageable, but currently incurable. So next I'm going to talk about prevention and control. Prevention and control is very difficult in a public setting. Tuberculosis is highly contagious, so if someone has active TB, it's going to run rampant. It's airborne, so all someone has to do is breathe the particles out and someone else breathes it in. We've already talked about transmission earlier. Alice explained it well. So if you know someone has active tuberculosis in a public setting, you want to avoid contact with them, make sure you're disinfecting surfaces around them, wear a mask if possible, have the patient with active TB wearing a mask, and avoiding contact. In a hospital setting, like the hospital I work, they have very specific precautions set up for suspected tuberculosis. There are 3 levels of TB infection control in the hospital I work at, and I think it's pretty common amongst hospitals around the nation. The first level of infection control is administrative. So basically they try to keep the patient out of any public space where they could infect other people. So there are protocols put into place that isolate the patient. We would put a mask on them. We'd try to keep them out of as many public spaces as possible just to limit the area of contagion. The second level of control is environmental control. We have rooms on our medical floor and also in our ICU that are reverse isolation rooms that we put patients in with suspected tuberculosis. They have a negative airflow. Basically, it sucks the air out of the room. So that if there are any airborne particles, the idea is that they'll be removed through the ventilation system. We would also keep doors closed whenever possible, and then also limit access to the room for family members and also practitioners, just only necessary personnel. And finally, the third level of control is respiratory protective equipment. This is something that I use a lot in the hospital for airborne isolation rooms. The one we use in our hospital is called a PAPR. It's a powered air purifying respirator with a high efficiency filter. It looks like a spacesuit. You have a little motor that you connect around your waist on a belt. You attach it to a mask that you wear that covers your entire head, and it provides airflow inside the mask. But the idea is that it protects you from any airborne particles inside the room. So to close our presentation, I'm going to tell you a spooky Halloween story about a close shave I had with tuberculosis. So I'd worked an entire shift with a patient on one of our medical floors. We'd been giving him breathing treatments throughout the day, and I came back to the hospital the next day and was told that he had some suspicious signs of tuberculosis. He'd had a suspicious x-ray. They'd found some nodules inside the lungs. He'd been coughing up blood, and also he was getting night sweats, and those are 3 of the hallmarks of tuberculosis. So needless to say, I was a little nervous. According to CDC guidelines, I had to wait 8 weeks between time of exposure and when I could do the IGRA blood test. Thankfully I tested negative, but it was a very scary 8 weeks, just kind of running all the what-ifs through my head. So anyway, that's our presentation on tuberculosis. Hope you've enjoyed it. We enjoyed researching it, and thank you very much for watching.